Email is the way to go.
Yeah.
Get both of you via email.
Well,
Yeah. Cool. She has just be good. Corey in Minnesota or LAX, yeah.
She was in Boston. She was fine. Yeah, she's like, oh, I have to wake up at 4 o'clock. And I'm like, oh, I feel so bad for you.
I know.
4 o'clock to go to Hawaii.
Yeah. Did she
Who's
sleep?
going with?
I don't know if Anthony's going or not. I think it's just her parents and her brother. But
Wasn't she thinking she was gonna get? Wasn't she thinking she was gonna get engaged?
Yeah, like maybe in Hawaii, maybe he is going.
I thought this was like before she thought she was getting engaged.
They thought maybe Pasadena, but that was like his work trip.
Oh.
Or not Pasadena. What's a desert in California that's like super hot, and they have the
They went to
Stagecoach.
Yeah. I can't remember.
What?
I know what you're talking about.
Yeah.
Because she went to say
Coachella.
She went to go see Justin Bieber, right?
Yeah. She saw Billy Zimmerman too. It's just. I mean, it's been a lot. But yeah, and
she goes on.
If she has to be to work at 8:30, she literally will roll out of bed at 7:30, brush her teeth, put clothes on, and walk out the door.
You're gonna laugh so hard.
The amount of freedom, I cannot imagine.
Last week, on Thursday, right? She didn't send it to me in a PDF. She sent it to me in a PDF form and not the PowerPoint form. So I'm literally up there and I'm like, well, shit, I can't present off of a PDF this whole time, right? So I call her and it's like 7:28. I'm like, are you even out of bed yet? She's like, my alarm was just about to go off. She was like, I was wondering who was calling me.
Yeah. Honestly, I just can't get over that freedom, and I love it for her.
Right.
And she's like, well, what time do you get up? I'm like, my alarm goes off at 5:15. I snooze for 5 minutes, and then I'm up at 5:20. To like, I just want to wake up. Yeah, and I like to have some quiet time just for myself in the morning, and then kind of like figure out my day, reply to all my emails. I check Facebook in case there's anything that came up about BayCare.
Oh, I'm done. Thank you. This driver played goals here. All right, man. Very good. Okay. I love mountain.
I hope my son always treats me like that. He better.
I always tell
He
him.
won't from about 13 to 21.
13 to 20 minutes.
And then
he'll come back.
Love your mom again.
Yeah.
Okay.
I always tell my son, I was like, what do you have to remember? He's like, I'll always be a mom.
Does she need
I
help?
mean, I love that for you, not your future daughter-in-law.
Yeah.
That's amazing. I love that. Okay, good luck, Dr. Zums. You're gonna kill it.
Thank you.
Yes. Can I still like listen online if I like lives? Yeah.
Do you have the link?
I'm going to sign up for it real quick.
We'll just.
Do you want me to forward it to you?
Yeah.
I have to save it.
You're right.
So.
Sorry, I gotta go back. Molly Linsmeyer just texted me asking me for all my upcoming events for her daughter.
Do you have the link?
I sent it to him already.
Oh, you did? Yeah, send it my way.
That's fun.
Have a great day. Good luck.
See ya.
You know if you need anything.
I will.
Where are you? I'm good. You know what? I gotta look through that pile of stuff that I put out. Did I put your stickers in there? Oh, yeah. So. Oh, you got it?
Yeah.
Yeah. She's like, you need to write that tomorrow. That came quick.
Yeah.
That wasn't that long. Good morning. Welcome. So Dr. Zems will go first, and your PowerPoint is actually loaded right in behind his. Right. So when he gets to his thank you slide, yours will be the next slide. But there's coffee and breakfast over there, guys, too.
Thank you guys for coming. Really appreciate it. Again, there's some goodies and handouts over here. Just quickly, around the corner is the restroom. If you guys need to go, please just get up and go whenever you need, and then come back. Get your refreshments. You need more to eat, need more to drink, please just go ahead and it's there. We
will replace most commonly. You can do an ankle, you can do a wrist. They don't do nearly as well, but those are out there. But these three, it's the most common surgeries that are done in America, and it's because they work. So hip and knee replacements, by far the most common surgery in the United States every year. Knee is probably the most common. It is obviously, and it's also the most difficult. So knee replacements are very painful. The first 6 to 10 weeks are very tough. It's really hard to work on that range of motion to get that back. But once you get through that recovery process, typically by about 6 months is when folks feel like, okay, I can do the things that I want to do and my knee doesn't hurt anymore. Hip and shoulder are actually very forgiving. So most people by 6 weeks, you can tell that people that you wouldn't be able to tell that you had your joint replaced because you're able to walk normally. You're not limping. You're not using a cane or any type of assistance. Hold on. There we go. All right, so knee replacement. Again, it's replacing just a worn out joint. So what ends up happening is you have about a 7 millimeter thick layer of cartilage over the ends of your bones. It's just low friction paint essentially that allows that joint to move. So once that wears out and bone's rubbing on bone, it's kind of like a pumice stone. You're grinding away on that tissue and it causes pain because the lining of your joint has very sensitive nerve endings. And when that bone is grinding away on it, it creates that inflammation that's causing pain because arthritis just means inflammation of a joint. So that's why things like ibuprofen, Tylenol, and other things help because it reduces that inflammation, but it doesn't stop it. It's metal and plastic components, and the really kind of like, I guess the biggest new thing that's come out in the last 5 to 10 years is it used to be that we would cement these components into place. So those metal caps that we put on the ends of the bones would be cemented into place. The problem is over time, as that plastic piece wears down, the particles that we're breaking off are the same size as bacteria. So your body, while it's eating the particles because it thinks it's a bacteria, it also is eating the bone. So that's why we would say, well, within 12 to 15 years, you might need to have a second surgery to get your knee redone. Well, now they've changed that. The plastic piece that we use inside your knee, the components that break off are not the same size as bacteria anymore. So we don't have that problem with loosening. And the back of the components is designed to be press fit into your knee, so your bone actually grows into the implant and it becomes a part of you. So instead of it being something that can get loose, it's not, because now it is a part of your bone. Your bone doesn't know that it's metal, it grows right into that implant. So so the candidates and outcomes, pain with walking in stairs, stiffness, swelling, and the big one is always doing conservative management, trying some physical therapy, activity modifications, medications, injections, all these other things that can be done short of doing a knee replacement to see if we can't buy you some time or kick the can down the road. But if you're young enough, the any kind of joint degenerative changes, they are progressive. So if you live long enough, you're going to end up with something that needs to be taken care of. So hip replacement, like I said at the beginning, a very forgiving type of surgery. We basically cut through the top portion of the thigh bone, remove the ball, and basically put a stem down the inside of your upper thigh bone to attach a new ball. On the socket side, we ream to put a small shell in there, which has a plastic liner to it, and that's what becomes your new hip. The most common right now is a ceramic head with a plastic polyethylene liner. The expectation with that is that should last at least 35 years. So for the most part, if you get your hip replaced, that's going to be your hip for the rest of your life. Very long lasting results. And the key to the hip is much different than the knee, because you have much more range of motion in a hip joint and it's not directly under the skin like your knee is. So again, very forgiving. Most folks are typically only using a walker for the first week or two, maybe transitioning to a cane at that point. But again, by 6 weeks, the vast majority of my patients who come into the office, nobody in the waiting room would know that you've had your hip replaced, because you walk in without a limp, you're not having pain, and you're very happy about how things are going. Typically by 3 months, you shouldn't even be thinking about your hip anymore. So same thing, groin pain is typically how most people present with hip problems. Standing for longer periods of time, longer walking seems to cause problems. But the thing that typically drives folks into the office is when they stop being able to sleep well. So, you get 3 or 4 hours of sleep, you start having pain in your hip, or you roll over and you have that sharp pain in the groin, wakes you up, and you can't get that good rest. That's when it's a good time to come in. And then shoulder replacement. So shoulders, again, like the hip, because it has so much mobility to it, a very, again, forgiving type of joint to replace. It's similar to the hip in that it's a ball in a socket, but the difference is, the analogy I use for folks with a shoulder is the shoulder joint's like a golf ball sitting on a tee. So it's a very large ball in a very small socket. So the stability to your shoulder is all designed by your rotator cuff. So the rotator cuff is a group of 4 muscles that keeps that shoulder stabilized. And so there's 2 reasons that folks end up needing a shoulder replacement or wanting one. The first one is the arthritis, the same as the other 2 joints. The cartilage wears away and you're having pain. The other one is a chronic rotator cuff issue, where the rotator cuff just doesn't function appropriately. It's not fixable because the tendon and the muscle are no longer healthy. And in that situation, we can't fix that shoulder in any other way other than doing a replacement. And there's 2 different ways of doing it. So the first way we describe, where it's arthritis and the cartilage wears out, we keep the socket where it is and the ball where it is, and we just replace them, kind of like we did with the other 2 joints. In folks with rotator cuff issues, which most people over the age of 60 have, we do what's called a reverse. So I switch that around, and if you look at the picture, you can see now the ball is where the socket was, and the socket is on the arm bone side. And what that allows us to do is your outer muscle, which is the deltoid of your arm, becomes your rotator cuff. So the rotator cuff isn't functioning, but you don't need it, because the way this functions is it's a lever arm now to allow you to lift your arm, get it over your head. Again, I'd say 80% of the shoulder replacements that are done beyond the age of 65 are done with a reverse, because even if the rotator cuff is still intact at the time of the surgery, it's a diseased rotator cuff and not healthy. So if we did a traditional shoulder replacement, if anything happened to your cuff, we would need to revise it and change it to a reverse, because it's no longer functional, because your cuff doesn't work. So it's a very, again, good outcomes. Most people by 6 to 8 weeks, again, are back to their lives. They're sleeping through the night and they're not having the same kind of pain that they were having previously. So what to expect? Evaluation and imaging. Typically your first visit in, we'll get some x-rays, kind of see what your baseline is for the joint. And depending on the level of pain that you're having, almost universally, we'll at least start with some physical therapy to try to improve mobility. As a joint becomes stiff and arthritic, that increases the pressure inside the joint, and that pressure is what creates the pain. So if we can loosen that joint a bit and lower the pressure, a lot of times that reduces some of the discomfort. Doesn't eliminate the problem, but improves the symptoms. Step two would be injections with steroids. So a steroid basically reduces inflammation. It works like ibuprofen. So I tell folks it's basically like you taking 4 ibuprofen pills and sticking them in the joint. It reduces that inflammation, reduces the symptoms temporarily. So again, like I mentioned before, it's kind of like kicking the can down the road. So the physical therapy, injections, the one that's most difficult is activity modifications. So if we reduce some of the things that are creating the pain in your joint, sometimes that will improve the symptoms. But a lot of times the whole purpose of the joint replacement is so that you don't have to. So that if you enjoy playing pickleball or you enjoy going to the gym and working out and lifting weights or going on the treadmill, well then if that's the case, the joint replacement would fix that so you can go back. So surgery and rehabilitation, the key to it is, I joke with my folks, it's like you can paint the Mona Lisa, but if you throw mud on it afterwards, it's not worth anything. So if you do the joint replacement, but you don't do the rehab, you'll be unhappy with the recovery and with the process of it, and you'll still have a stiff and painful joint that you don't like. If you do the surgery and you're very dedicated to your rehab over that first 6 to 12 weeks, you'll be very happy with that joint replacement and how it changes your life. The vast majority of folks who I replace their joint typically come into my office at their last visit and say, I don't know why I didn't do this 5 years ago. So it is life-changing kind of procedure. Unlike other conditions like diabetes or cancer and other kind of stuff where we kind of have to manage it, with joint replacement, the problem's gone. You know, you went from having an arthritic joint and now you don't. So it's one procedure and it's done. You have a good joint that will last you the rest of your life and you can enjoy the things that you do typically. So if there is any questions that you have, more than happy to answer them. Yes, ma'am.
Can you do everything, scratch the middle of your back?
It's interesting that you say that. So yes, you can get, I tell folks about 90% of your range of motion after surgery will return. And what that is getting your hand to your face, to the back of your head. But internal rotation, which is what it is when you go behind your back, is the one thing with a reverse shoulder replacement that is difficult to get all of that motion back. So most people can get their hand to their back pocket, but not to the middle of their back to scratch it, because the way that shoulder is designed, it doesn't allow for that rotation. So you can get, like I said, 90% of that mobility back, but that last 10% of rotation for your arm to go behind your back is difficult just because of the nature of the shape of the joint. Sorry.
Is that when you feel like people start doing everything you're used to doing and you'll gain more possibilities as time goes on and if you are
Yeah, I would say for any joint replacement, they're all obviously different and everybody recovers a little bit differently. But on average, by 12 weeks, you should be able to do everything that you were doing before with very minimal pain. You still may notice that your joint isn't completely normal yet at 12 weeks. So I tell folks your finish line is 6 months. At 6 months, you shouldn't be thinking about your joint. You should be able to do anything you want to do without pain. Yes, ma'am.
Person has a knee replacement and they want to kneel down, they feel that very uncomfortableness. Is that typical? I mean, it's not real painful, but it's kind of like, I can't really kneel on my knees anymore.
Yes, so that is very common, and I do talk to all of my patients about it during the preoperative kind of process about knee replacement. The one thing that is difficult after a knee replacement that you really can't get back is kneeling. So it's not that you're doing damage to the joint, you're not hurting anything with the implants that are in your knee, but the way that joint is designed, it is just uncomfortable to kneel on it. So, you know, I've had patients who talk about the fact that they can no longer kneel at church. They can't, even with that padded step, it's difficult and uncomfortable for them. And so that's common.
Nursing home for 2 weeks because it's home. So when you're doing rehab and they're always talking about, we got to break through that scar tissue, got to break through this scar tissue. And I'm thinking, well, if we have to break through that right away and you're walking the same day as surgery, Why not do that when they're still half asleep? Just break through that right away.
Sure.
Boy, it hurts a couple days later.
Absolutely. So what I tell everybody is at the end of the case, like when I'm done with surgery and you're getting wheeled into the pre-op area, your knee will be allowed to go fully straight and it will bend to typically about 135 degrees. So you will have that full mobility. So if you wanted to post-operatively, you could get up and bend your knee to 135 degrees. The problem is it hurts. That's the key. And there's this delicate balance between scarring in an appropriate way, because obviously your tissue has to heal. So when we repair that extensor mechanism through your thigh, that tissue has to heal to itself, and it heals by scarring. So we want that. But while it's healing and scarring, we want to keep maintaining that mobility so it doesn't scar so tightly that you can't move your joint. There's a very small subset, about 1% of patients who get a joint replacement, or knee in particular, where that mobility, for whatever reason, you scar too quickly, you just can't get that mobility back. And we have to do what's called a manipulation, where put you back to sleep, we take you into the operating room, and we force the knee and break up that scar tissue so that the knee gets that mobility back. And typically, I'd say 80% of the time, that restores the motion, and you can kind of get back to your life.
So how many should you be at that point, 120? Because I can only get to 100. And about 4 or 5 days into rehab, she forced it. And I think they heard me at the other end of the minute.
Yeah, we pay them extra for that. So, yeah, so I always joke, yeah, you're going to have some 100-pound small female, and you're cranking on your knee and it's going to hurt. But so yes, like the more you can get back during those therapy sessions is very important. And it's all a matter of, what you can tolerate. And the key to it too is on the days that you're not in physical therapy is maintaining that home exercise program. Because if you don't do those exercises every day, you will struggle and that knee is going to get tight. So functional range of motion for a knee is 115 degrees. That allows you to go up and down stairs normally. You can ride a bike normally, and you can get out of a chair normally. If you have less than that, those things can be difficult because that's how many degrees you need. So I always tell my patients a victory is 115 degrees. If you can get more than that, that's excellent. I mean, I've had patients who get to 135 degrees after surgery. But I'd say on average, between 120 and 125 is probably what I typically would see. If you're at 115, you might still be a little bit uncomfortable with certain activities, but again, you have that functional mobility. Less than 115, I talk to folks either about manipulation, or sometimes we go back in with a scope after surgery to debride away that scar tissue. I had a gentleman who had his knee replaced about 5 years ago at another facility, was struggling, wasn't making any progress, and nothing that they were trying was helping. But I've developed this procedure through the scope where we basically go back into the knee. I take away that front layer of scar tissue in the beginning of the knee. So when I first start that surgery, I can't even get into the area where the kneecap is in your joint because it's so tight. So we debride away that scar tissue. It takes about 25 to 30 minutes because it's so much and it's so dense. But at the end of that procedure, I can get into the top portion of your joint. I can get between the kneecap and your thigh. And that mobility typically improves by about 15 to 20%. Just did one recently. He came in at his 2-week visit, already had 20 degrees more mobility, and the pain that he had been having was gone. So it is really an effective procedure if you're one of those very few patients who struggles with that mobility. Yeah, because he was 5 years post-op when I went in and did it. Yes, ma'am.
That reverse.
It came out probably about 15 years ago, but almost nobody was doing it because it's such a kind of a novel approach to replacing a shoulder, and it seems, counterintuitive to change the whole joint around like that. And it does change the appearance of your shoulder as well. So normally we don't have that normal roundedness to the side of our shoulders. When you do a reverse, it drops the shoulder down, so that part of your shoulder becomes flat instead of rounded. And so it was very slow in the beginning. I went to a course about reverse total shoulders about 12 years ago. And if they did a show of hands, there's about 120 orthopedic surgeons in the room. And they said, how many people are doing reverse and how many are doing anatomic? And the numbers were about, 20% reverse, 80% anatomic. I went to a similar course 3 years ago, and they did the same question they asked, and it was completely opposite. It was almost 80% were now doing reverse for everybody, and 20% were doing anatomic. So, because as the technology has improved, We get specific CT scans ahead of time, and we have a computer that can analyze your shoulder, and it gives us the perfect information about how much or how big the implants should be and where we're going to position your shoulder to optimize that range of motion after surgery. So the technology and the things that we've been able to do in the last 5 years has made it a very reproducible procedure, and patients do very, very well.
The only joint that they do that reverse?
Yes, there is. Yeah, the hip and the knee wouldn't respond to that kind of a procedure, and it's all about that analogy I talked about in the beginning. How it's that golf ball sitting on a tee. It's a very, very large ball with a small socket, so you can't really reproduce that without doing that reverse. Anyone? Oh, yes, ma'am.
So changing where the particles will break off, so now they don't.
Yeah.
What's time? When did that change?
The change to that polyethylene happened in the 2010 to 2015 timeframe. And that's when, and it's funny because it also coincided with the whole idea of the press fit total knee, which I was describing, where the back of that implant, it basically mimics bone. So it tricks your body into thinking it's bone. So your bone grows into it and it becomes a part of you. So we have that implant now that is basically grown into your bone. And we have this plastic piece that no longer wears away that same direction or the same way it did before. So we're seeing, obviously, and this has only been around for 15 years. So while we're telling people it's probably going to be 35 to 40 years before we'd have to do anything else to your knee, we don't have that much time to be able to prove that. But the results are pretty clear. I mean, we've had patients coming in 15, 16 years out from this newer type of total knee. Their components look perfect. There's no signs of loosening. The bone looks perfect, and the patient's happy with their joint. Yes, ma'am. Yeah.
Teeter.
Me too.
Social media about different devices that can use. There's one called BayCare to avoid shoulder surgery. Are those all just kicking the can down the road kind of things? Scams, or are those legit?
I'm not familiar with Recare, but a lot of the ones that are advertised online, I don't want to say it's snake oil, but a lot of them are, you're basically trying to, so the placebo effect, where we give you something that has no treatment value to it, 35% of people with a placebo will still get improvement. So when you do things like that, there's about a third of people who will use it who will tell you that, yes, it absolutely worked for me, I got better, but there isn't any science behind it. So most of those things are things that are done treatment wise, because it is, I mean, it's a very attractive offer where somebody can say, well, hey, we don't have to rip your shoulder open. I can just give you this other thing and it's going to improve your symptoms. So there's value to that in the sense that, okay, it's less expensive, may give you some relief. And if you're one of those 30%, well, it's great for you. Gives you that relief to your symptoms. But at the end of the day, when you have mechanical damage in a joint, there isn't anything that we've been able to figure out yet that fixes that short of a joint replacement. In the future, could there be stem cell therapy and other things that we could potentially regrow cartilage in a joint and restore it back to where it was previously? Yeah, that's probably out there, but we're looking probably 30 to 40 years down the road before we figure that one out. Because we have stem cell injections that we do now, very expensive. I mean, we're looking like $10,000 to $12,000. It's not covered by insurance. And the key right now is, even though we know there's stem cells in that injection that we're putting into your joint, we don't know how to take that stem cell and tell it to turn into cartilage. So that's the problem. It's the signal that we don't know how to do. And that's the thing that they're working on to try to figure it out. So the key to that is where you break. So like when we were showing you that picture at the top, where you see those two bumps at the top of the thigh bone, and there's the piece that leads up to the ball, that's called the femoral neck. So if you break through the femoral neck, then yes, I talk to all of my patients who come into the hospital, depending on when their age and their mobility status prior to their injury, we just replace the joint. So I do a total hip replacement and get you back up and running. If you break below the femoral neck, so kind of more to the thigh bone region, well, then we have to repair it. So we repair it in a way that you can walk immediately. You get up, you start walking on it. Once the bone is completely healed, then we would have to come back, once you're completely healed and not having symptoms, to take that hardware back out so that we can do your replacement. Yes.
I broke my femur and that has been repaired and I have a rod in my leg. And I do need to have that same knee replaced.
Yeah.
Is that an issue?
Yeah. So your surgeon will want to take that, the nail out, because the way we design the thigh bone component, we have to put a rod up your leg to design where we put the implant. So the nail that they had put in would be in the way, unless it was a short nail. Because there are some, you can either do a short nail that stops about mid-thigh, or you can do a long one that goes all the way down to the knee. If you have the one that's into your knee, you would have to have it removed ahead of time. Excuse me. And typically the way we do that is we take the nail out, let you recover for 6 weeks, and then we come back and do the joint because it decreases the risk of an infection. Of course. Yeah. Sorry?
Brucitis.
Yes.
And I've had it probably almost 30 years.
Oh, wow.
And I started exercise and it doesn't give me, when I got it, it gave me trouble. I would catch and I could, and then I went into exercise and tried a shot. And then they said, because I wasn't ready for surgery, but if bursitis is painful actually. It started. So anyway, the doctor actually, chiropractor, who worked on it. And he gave me exercise, and so I've been exercising for all that while. And I'm 86 years old, going to be 87. So by the time something happens, like I don't have any pain, and I don't have any pain sleeping or anything. So, but does it make your leg a little bit weaker?
Well, it can. If it's just bursitis, then no. Typically, your strength doesn't change in the leg. But the other thing in the same area is there's 3 muscles from your butt that attach to the area where your bursa is. And there's the middle one, which is called your gluteus medius, is the one that a lot of times will tear. So if you have a tear to that muscle, in addition to the bursitis, it does change the strength of your leg. And so for my patients who are recalcitrant to treatment, where I try injections and therapy and everything else, and you're still having pain, in those folks, I'll get an MRI of the hip to look at that tendon. Because in some patients, it's the tear that's causing the problem, not the bursitis. But it feels exactly the same. The only way to differentiate the two is to get the MRI. True. And I tell all of my folks, anybody who has a hip problem has a back problem. They're interrelated 95% of the time. You really can't have one without the other.
Yeah.
You're very welcome. Anything else? Thank you for having me. It was really nice talking with you. Great questions. I really enjoyed talking to you guys. If there's anything else you need, please just contact my office and get you taken care of.
Give you guys like about 5 minutes, and then we will start our next presentation. Yeah. For you, I mean.
No, I'm like.
Doesn't so 3 plus years. We just do what else. I'm not saying it's right. Or
Please, no. If I don't need one, whatever, that is fine, it's not.
you said you're not counting 3 months.
Yeah.
That's too. Then we do. 5 year time.
I'm 100.
Doesn't. That are not here.
All right, out the pain.
That's what it is. Older. Mobility, good like. I know the other one. Trying to design.
I would say, I would, did always recommend it.
It's different, that's for a joint class.
You're not in sentence.
Yeah, so that's all.
But again, lots of people. It's the, yeah, but it's permanent. And do not, it's rehab. And so that we don't see any info here. It's better. Let's see. So, that's what it's like he's just doing, it's just like that, and they said, I'm. So, and it's a movie. And let's get it right away. There's the last lady. If. Sport. I could want to. And look at this. That was another. I want to lay her in ambulance. Oh, we break one. It is get all this. Right. Orange club. It was we get all our boss. Just like it's from the school. You're already afraid of it. We should win. I shouldn't be able to hold it. Me and he was on spot. On the way to the so then I tried to go out and was totally off. It's a French girl. And yeah. Thank you, Ms. Lord. I know, it. Really hard. Right. I know.
All right, good morning, everyone. We'll get started with Dr. Dixon and her presentation on gynecological health signs and symptoms. Before she kicks that off, I just want to let you know we've got some great flyers over there. There's some information on Dr. Zems and the orthopedics practice, and we also have some information on Dr. Dixon and her practice, plus one of our favorite events of the year that Dr. Dixon hosts. It's called Tech Girls, and we are in the other building that's that way. On the Aurora BayCare campus, and it's a day for girls 8 to 18 to encourage them to stick with science, technology, engineering, mathematics, arts. So it's a great day. They get to come in and they get to play with all the things that our doctors, our nurse practitioners, our physician assistants, surgical techs, everybody that keeps this hospital running. They get to do hands-on things. So play with a surgical robot, dissect a cow eyeball, play with lasers, see how blood gets injected through veins, and all of these great, crazy things to keep them interested in science and technology and engineering. So this is a flyer. If you have any young girls in your life that you think would like that, please take one with you. It's free. It's in the summertime. 1:30 to 3:30. So it's a great little afternoon. And we've got a great newsletter as well. So I will let Dr. Dixon take it away and introduce it. Okay. Okay.
All right. Hi, everybody. Thank you for letting me come and speak with you about GYN care. And this is a talk which I hope is going to be interactive, but there is a lot of material, so I sometimes talk too fast. So if you need me to slow down or you have questions, please interrupt me. But the big thing is a lot of times we are told when we're women that after we're done having babies, that's it. That our GYN care isn't necessarily our top forefront of what we should be thinking about anymore, but really that's not the case. And then just because we're done with periods and having babies does not mean that we don't have GYN issues. And so in our practice, we try and make sure that we are looking at every patient as them and themselves rather than just their disease or their illness. So we want to make sure that we are taking care of patients at all times during their life, not just during the time of their babies, and make sure that we are giving the patients what they need every day. So we're going to talk a little bit about what cancer is, and then we'll talk about the GYN cancers, which is what we take care of in our practice. And then we'll talk about a little bit ways we can treat those, different signs and symptoms to watch out for, and things that you can kind of look into. So what exactly is cancer? So cancer, by definition, is your cells that have decided to change and not listen to your body's and regulatory mechanisms. So they are your specific cells. And that's what we're really trying to do now with cancer care, is actually try and make things based on you, yourself, and do what's called personalized medicine, as opposed to what we used to do 10 to 15 years ago, which is give everybody the same thing and hope it works. But now we know that because cancer is your specific genes, we need to really target those genes and those changes with our treatments. So this is kind of a graphic depiction of what actually happens. So your normal cells, if they are told by your body to be a certain thing, they keep being that certain thing during your lifetime. You don't grow a third eye unless you're Dr. Strange from the Marvel. You have 2 eyes and that's it. Your cancer cells have decided to not listen to any of those things. So they don't listen to what your body tells them to be. So they decide to change. They don't listen to your body says to grow. So they grow when they're not supposed to. And then they also don't listen to your body and stay where they're supposed to be. So they try and leave. So this is kind of a depiction, picture-wise, of how that happens. And the big thing with growth, and what we talk about with growth, is that those growth mechanisms that our body is telling them to stop growing, they get around them. And so some of the times when we try and treat cancer, we're trying to actually stop the cancer's ability to get around those growth signals. But sometimes even with that, the cancer decides to rebel. So I'm sure if I asked everybody to raise their hands, if you know someone or you personally have been touched by cancer, almost every single person in this room will raise their hand. And the problem is, for different cancers, they're actually going up in incidence, not down. And so in the state of Wisconsin, over 42,000 people will be diagnosed with cancer this year. And one of the ones that we treat with women's cancer that's going up in incidence is actually uterine cancer or womb cancer or endometrial cancer. And that number is going up, and we'll talk a little bit about why. But part of the reason that's going up is because we don't talk about what to watch out for with the signs and symptoms that could be heralding us into these cancers. But with female cancers, still lung is the number one. Go to this slide. Still breast as far as incident, but as far as death by cancer, lung is number one. And then the other ones that are actually going up is the ones that are going up are actually some of the ones we have screening tools for. So not every cancer has a screening tool. So there's not something that we can do to try and catch cancer before it becomes cancer in the pre-cancer state. And so those screening tools that we do have, things like mammograms, colonoscopies, pap smears, those cancers are actually going up rather than going down. And a lot of people, and this is all speculation, but a lot of people are blaming COVID and the fact that COVID changed the public's view on healthcare. And a lot of patients are not trusting some of the things that we do as far as our screening mechanisms. And so they're not getting their screening anymore. So, yeah.
What group of
Each one is going.
So that's a great question. It's actually young patients. So younger patients are getting cancer more frequently. And so the younger group are not going and getting their screening. We don't know why that is, but one of the thought processes, what happened with COVID and the change in the public's view on healthcare. But as far as the other ones, again, colorectal, breast, thyroid cancer, pancreatic cancer, and endometrial cancer are big ones that are all going up in incidence, not down. And the sad part about a lot of those are that they are the ones that we can actually do screening tests for or physical exams for and find them early and catch them early. So this kind of goes a little bit more into the different ways that the cell decides not to listen to what our body is telling it to do. And so, because we have a lot of information, I'll just kind of brief that one. Okay. So one of the big things that we are actually finding out more and more about with cancer care is stress and cortisol. Cortisol is a buzzword that a lot of patients are hearing about for other things like diabetes, weight gain, other problems, but actually we're finding more and more that the stress and cortisol levels actually influence cancer. And so cancer actually is a lot more attuned with those hormones than we used to think. And so anything that we can do, which we'll talk about a little bit later, to try and decrease our cortisol levels helps overall with everything. With every single part of our bodies, if we can try and decrease our cortisol levels, we actually will help improve our overall health. So when we're looking for information, big thing now is AI and ChatGPT and putting things into AI and trying to find information. And so AI and the web are great information sources if you use them in the right way. But the problem with all of that is it's very generalized. So it's not you. And that's what I'm going to keep going back to with all of our talk today is what is going to be best for you and what is going on with you. It's not what ChatGPT or AI tells you. It's actually what's happening with you in your body. And so that's what we're going to kind of keep focusing on. So what are our 5 cancers? So the 5 cancers, the biggest ones that we treat in our clinic are endometrial or uterine cancer, ovarian cancer, cervical cancer, vulvar cancer, and less likely vaginal cancer just because it's more rare. But these are our big ones. And so the big thing that actually goes with all of these is irregular bleeding. So after menopause, so the definition of menopause, so backtracking. Now, a lot of people are asking about hormones and should we be looking at hormones and should we be checking your estrogen and your progesterone, which are your 2 biggest ones as women? Should we be looking at that to try and figure out when people are actually in menopause? What should we look at from the hormone? But the actual definition of menopause is you don't have a period for a year. That's it. So it doesn't matter what your estrogen is, doesn't matter what your FSH is, all your other hormones, it's you don't have a period for a year. After not having a period for a year, any bleeding is irregular. So any bleeding at all is something that you have to talk to somebody about. And a lot of women don't know that. Or a lot of women think because they keep having periods through the age of 50, 55, 60, 65, that is normal. Not necessarily. It could be, for sure. But that's definitely something to talk to your providers about is, hey, I haven't had a period for 3 years and now I'm spotting every day. That's not normal. And it might not be a GYN issue. It might be a bladder issue because as ladies, we also have the benefit of having 3 different things all in the same spot. So we have your urethra, your urine, your bladder, we have the vagina, and then we have the rectum. And so unfortunately, as we get older, we don't bend that way anymore. So to be able to see where it's coming from or what's going on down there, 9 times out of 10 patients have no idea. They saw a spot, but that's it. And when we talk about it's from the front or from the back, half the time it's not from either one of those spots. It's actually from the opposite. So any bleeding postmenopausally is something to talk to your provider about because any bleeding at all could be a sign for something going on. The other thing is a lot of women don't understand their anatomy. And we never really talk about it past, 2nd or 3rd grade. And that's a long time ago sometimes. And a lot of women don't understand their anatomy. So this is it. So uterus is the main area where if you were to be pregnant, that's what we're looking at. Can you see the arrow? I don't have a pointer. Okay. So the uterus is actually where, if there was a pregnancy, that would be kind of housed. And then if we are going to have a period, the endometrium, which is the lining of the uterus, is what comes out. So when we talk about uterine cancer, we use uterine cancer and endometrium interchangeably, but really the endometrium is just that lining. Then we have our ovaries, which the ovaries have eggs, which are released to make babies. And any part of that egg, any cell of that egg can go crazy and become a cancer. So that's one of the reasons why ovarian cancer is so difficult to either find or treat, is because it could be any cell that made you could potentially become a cancer. And then we have the fallopian tubes, which we actually think may be part of the precursors of ovarian cancer. The cervix is the outside of the uterus, and then the vagina. And then a lot of patients too, when they're told they had a hysterectomy, and they talk about a total hysterectomy is just the uterus and cervix. If you had your ovaries removed as well and your fallopian tubes, that's a bilateral salpingo oophorectomy. So that's a BSO. So some patients come in after many, many years after having their hysterectomy with ovarian problems because they didn't know their ovaries were left behind because they were told they had a total hysterectomy. Total hysterectomy is just the uterus and the cervix. It's not the other parts. And then sometimes we have patients who come in who think that they had a total hysterectomy. They actually had a supracervical hysterectomy and their cervix is still there. And they haven't been getting any surveillance on their cervix because they thought they had a hysterectomy and their cervix was gone. So understanding all these different parts is really beneficial, especially if you do come in down the road with bleeding. What parts do you actually still have? And a lot of women don't know. So this is something that, again, for the education moving forward, that we have to kind of get out there what our parts are. So signs and symptoms, the big one, like I said, vaginal bleeding, or any bleeding actually, any bleeding that you see postmenopausally is something to look into. But the other signs and symptoms, which every single woman who is here and on the face of the planet at some point in their life has bloating. So unfortunately, that's a sign and symptom for us, is that your bloating changes, that your actual, how your GI system is feeling changes. But that's the problem that we have too with a lot of patients who come into our office, is they've been saying that they've had problems with bloating for the last year and nobody's been listening because they say it's normal. It's not necessarily normal if it's different for you. So say you have chronic constipation and you're always bloated, but then something happens and it's a change. So now instead of being bloated because you ate cheese all the time, now you're getting bloated other times. Or if instead of having constipation, now you have diarrhea. Something is different. But the problem is with a lot of women, they unfortunately go into their primaries with these weird kind of vague symptoms and they're told it's normal. If it continues and it's different, it's not normal. Other than that, things like pain with intercourse, vaginal pain, itching is a big one for vulvar cancer. So itching or burning on the outside. Things are just different down there. Talk to your provider about why it's different and what's happening. So ovarian cancer is our deadliest cancer at this point. I honestly don't know if endometrial cancer is going to surpass that just because it's becoming more prevalent. But right now for GYN cancers, ovarian cancer is the most deadly. And the reason is because we don't have a screening tool for it. And we also don't find it except when it's later on. And if you think about a woman's pelvis, whatever we want to say about politics or whatever, the woman's pelvis is actually made to have pregnancies. Evolutionarily, we are all supposed to be bearing children. But the problem with that is that the pelvis can actually hide things up until about 18 to 20 centimeters. If you think about having a pregnancy, you don't show, and people don't know you're pregnant until about halfway through. So that's about 18 to 20 centimeters. We can hide things in our pelvis and we don't even know that they're there until they cause problems. So that's one of the problems with ovarian cancer, is that it can hide in your pelvis until it starts causing problems. And most of the problems that it causes are very nonspecific and very GI related. So bloating, change in bowel habits. And until it gets past that point, so past the point of being hid, where it's stage 3 or stage 4, then we have problems outside of that, and that's when we find it. But the problem with ovarian cancer is we don't have a screening tool. We can't find it early. We try and do things with ultrasounds to look at ovaries and labs to look at ovaries, but they don't together actually pick up ovarian cancer any earlier. And so the increased risk, the couple of big ones for ovarian cancer are family history. So having some sort of a familial state, genetic mutations, and then as we get older, our risk of ovarian cancer goes up every year. And then this kind of talks a little bit about how with the ovary, we have so many different cells in there, then any of those cells can actually change and become cancer. So there's 3 different types of ovarian cancer. And the other problem with Googling and looking at AI is that when you do that, they're going to talk about the most common ovarian cancer. But sometimes that has nothing to do with what your cancer is, because your cancer is from a different part of the ovary. So that's part of the problem with Googling and trying to figure out information. But there's 3 different kinds. One is called the epithelial, which is the most common. That's the one, if you Google, you will see that one. Then there's germ cell tumors, and those are all the cells that could make a baby have gone crazy. And then there's sex cord stromal tumors, and those are the ones that actually secrete hormones. So you have patients who come in with very hirsutism, so basically they have beards and they have extra facial hair and things like that. Or if they have other symptoms that are showing that their estrogen is higher than it should be, things like that. So those are our different kinds of ovarian cancer. And we split them into type 1 and type 2 based on their gene changes. So what kinds of genes, which is where all of our cancer care is going, are changed, and we break them down into type 1 and type 2. So endometrial cancer, like we talked about, is on the rise. It's one of the GYN cancers that is going up in incidence, and the reason for that is the obesity epidemic. So unfortunately, as patients are becoming more obese, the adipose tissue actually converts into estrogen. And so you're getting a lot of extra estrogen in your body. And our 2 hormones that we have that balance each other are our estrogen and our progesterone. And our estrogen, when we are having periods, so when we're having periods every month, our estrogen builds up the lining of the uterine lining, which is called the endometrium. It builds that up. And if we're going to get pregnant, then it sticks around and becomes the placenta. If we're not, then your progesterone comes in and says, hey, knock it off. There's no pregnancy this month. We're going to have a period. And then you flush it all out, and then you do it all over again every month. After menopause, if you have estrogen building up that lining, or even before menopause, that's one of the other things, is that a lot of younger women are getting this as well, is that lining is built up by the estrogen, and there's no progesterone to come and make it say, hey, knock it off, stop doing that. So as our obesity epidemic goes up and up and up and up, and patients don't know that that is going to increase their estrogen without giving them their progesterone backing, that's going to increase the incidence of endometrial cancer. And unfortunately, too, we know that there's a lot of disparity in endometrial cancer numbers, and that the minority groups are actually going up as well. Part of it is access to healthcare, and the other part is education and trying to get this information out to them. So risk factors, kind of like we've talked about, the number 1 risk factor is obesity, but also any time where you have estrogen without that progesterone backing. So if you have irregular periods, if you have PCOS, where you have estrogen without any progesterone, anytime that estrogen is unopposed, that can increase your risk of endometrial cancer. And there is a syndrome called Lynch syndrome, which goes with a genetic change that can be in families that can cause endometrial cancer. And that goes with colon cancer and endometrial cancer. So it's called Lynch syndrome. And we look for those gene changes in tumors when we find them to see if this could potentially be a familial problem. Oh, so cervical cancer is so late. So this is cervical cancer. It's at the top there, I swear. There. Yes, I don't know what happened. So cervical cancer is our cancer that we have a screening tool that works, and we have a vaccine where we can eradicate cervical cancer. Australia actually has, no, again, nothing political, but Australia has mandatory vaccinations, and Australia is on the way to eradicating cervical cancer because they are forcing people to get vaccinated. Again, not political, just saying. We know that almost all cervical cancers, now there is a small component, so they won't be able to completely eradicate it, but there's a small component that's not HPV related. But the majority, 9 times out of 10, cervical cancer is associated with the human papilloma virus, or HPV. We have a vaccine for human papilloma virus. And so the problem with our vaccine is that we did not market it as a cancer killing vaccine. We marketed it as a vaccine for HPV, which unfortunately is sexually transmitted. The problem with HPV is that there's over 100 different types, and every single person who's ever had sexual contact ever in their life has HPV. Every single person. And we did a terrible job at getting that information out because everybody has HPV. And it's so prevalent and it's so out there, but we did not do a good job as providers at getting that information out. Problem with HPV, because there's over 100 different types, it depends on which types you potentially were exposed to, and also if your immune system can fight it. So if your immune system can suppress HPV, then you never have a problem. HPV is a similar virus to chickenpox. So the chickenpox or varicella virus, we all had chickenpox parties. Some people were vaccinated, but but when you were younger, one person in the class had chickenpox, then everybody had chickenpox. You all got it at the same time, you got it over with, and then you had it and you were done. That virus never left you. You all, if you had chickenpox, still have it. It is in your system, just hanging out. And then at times of stress, in times of immunocompromised, when your immune system can't suppress that chickenpox, it pops up as shingles. So the disease that is caused by the varicella virus in youth, which is chickenpox, is the same virus as shingles. And so everybody goes out and gets the shingles shot to try and help their bodies suppress the shingles because we know that shingles is terrible. HPV acts the exact same way. At some point in your life, after sexual contact, everybody's got HPV. And then it lays dormant. And if your body can suppress it and your immune system can fight it, great. And you do your pap smears and you keep doing what your screening is for HPV, fantastic. Then later in life, when you have other illnesses, when your immune system is shot, we saw a lot of people who have never had HPV on their pap smears come in after COVID, not because of COVID, but because of the stress of COVID. And then the HPV decides to change your cells. And so our screening for HPV and for cervical cancer, about 2019. So what is that now? Ooh, 7 years. So 7 years ago, they changed and lengthened the amount of time in between pap smears for our screening. I think in the next year or two, it's going to go back because I think a lot of patients just didn't come in for their pap smears in between that time because 5 years is a long time. Remember, you have to have a pap smear. And then I think it's going to go back. But the problem is, as we get older, again, we're told we don't have to think about that stuff anymore. But as we get older is when our immune system doesn't work anymore. And that's when sometimes HPV pops up. So how we think about HPV is changing as well, but we could eradicate cervical cancer if we all got vaccinated. So the way HPV actually changes those cells is it goes into your cells on your cervix. It also goes into your cells on your vagina and your vulva, and it changes them. And it starts by changing them into just low-grade changes, so precancer, and then eventually goes to cancer, but it takes a long time. So that's why those screenings lengthen out, because it can take up to 10 years from the first change all the way to cancer. And so that's why they changed how we do our pap smear screening, but I think we're going to go back because we used to get them every year. I think yearly is probably too much. It's probably going to be every 2 years. And then we kind of talked about this on why that happens. And so with HPV positive cancers, again, they change the cell's genes and they change the DNA, and then it becomes cancer over time. It's happening now. This is vulva. What happened? It worked. We used this like 2 weeks ago. So vulvar cancer, which is less of an incidence than cervical cancer, but caused by the same thing. So the majority of these are also caused by HPV, and that is slowly going up. And I think the biggest reason this one's going up is what we talked about earlier, is as ladies, we don't feel or can't look down there as we get older, and nobody else is looking either. And so because we don't do pelvic exams anymore, and actually, there are different societies that say pelvic exams are so stressful to women. They actually have said you don't need one and you don't need to even talk about them, that people aren't talking about our vulvar care. And there are other things besides cancer down there too. There are different syndromes like lichen sclerosis, which causes very itching and sometimes causes bleeding and causes delicate tissue. There are ulcers that can happen down there. There are yeast infections that can happen down there. Lots of different stuff can happen down there. And when we call with itching, a lot of the times we're just told that's normal, which isn't necessarily true. But nobody's looking down there anymore because about 10 years ago, different societies have said that we don't need to. ACOG, which is the American College of Obstetrics and Gynecology, still says we need to, but we're the only ones. Family practice, internal med, everybody else has said you don't need a pelvic exam anymore. So these are kind of the signs and symptoms for vulvar cancer. Again, anything on the outside that feels different could potentially be a sign and something to look into because we can't look down there. Vaginal cancer, again, is very rare and usually is secondary. So usually you don't have a primary vaginal cancer. It's either a metastasis or an extension of cervical cancer or vulvar cancer. So after we have a diagnosis of cancer, this slide should be someplace else. But anyway, so what happens with the recurrence? So when we treat cancer, we actually treat the cancer cells that are there, and we think when we got it all, we did. The problem is those cells that are there, we can't see cells. And so if one cell decides to stick around because they were resistant to whatever we did, so they were resistant to the treatment, they were resistant to the surgery, that cell can latch on and grow again, and that's what a recurrence is. So it's not necessarily a new cancer, it's that cell was resistant to whatever we did in the first place. So how do we treat these cancers? And there are different options depending on what cancer it actually is. So we have some cancers that are more receptive to chemotherapy. We have some cancers that are more receptive to radiation. We have some cancers that are susceptible to surgery. And then we also need to know, depending on when you're going to be treated for your cancer, what your goals are for fertility. Do you want to save your fertility? Do you not want to save your fertility? What are the different options that we have? And so one of the mainstays of GYN cancers is surgery. So one of the ways that we do surgery now is robotically. And most of my practice is with robotic surgery. And the way we do robotic surgery, it's actually with small incisions, minimally invasive. And really the only true cancer that we have that we don't usually use the robot for is ovarian, because again, we find it at a higher stage. So we find it where we can't actually do it with minimally invasive surgery. But most we try and do minimally invasive now because these patients can go home the same day. Afterwards, their pain is very tolerable because it's gas pain. It's not incision pain. And they're back to their normal lives so much quicker than we used to have to do it. As far as chemotherapy agents and what we can use for chemo, it used to be 10 years ago that we just gave chemotherapy that was basically a blast. So we give chemo to any cells that are trying to rapidly divide, depending on where they are in their cell cycle. So different chemotherapy drugs affect different parts of the way that the cell grows. So if the cell is going to get bigger and then start to divide, we can hit those different areas that the cell is trying to grow and divide with. That's how we used to do it, was nonspecific. It went to any cell that was rapidly dividing. So your hair got affected because your hair is always growing. Your bone marrow is always growing. your GI system. You got nausea because the lining is always changing and growing. So it used to be that we just hit everything with this blanket approach because we were trying to get any cells that are trying to rapidly divide. Now that we're going more towards actual targeted therapies, what are those cells that are actually changed with the genes that are making them cancer? Now we're trying to hit just those cells so the side effects are less. They're much better tolerated. And most of the time we don't lose our hair, which is something, especially as we as ladies, is really a big thing when we're talking about cancer care. Not only do I have this cancer, but now I also don't look like myself anymore, which we'll talk about a little bit too. And then radiation therapy. But radiation therapy sometimes is used for our endometrial cancers. But if anybody's had radiation, it can be very harmful. And so now they're actually trying to take, because if you think about what radiation is, it's burning. And it's kind of like taking a nuclear bomb to a cell. The cell is the ant, a nuclear bomb to the ant. And so now what they're trying to do is actually draw around where the actual tumor is with different, more targeted techniques. So that way they're having less of that radiation effect outside of the ant. It's more just on the ant and less around the tissue around it. And so this is a depiction of those different types of chemotherapy agents now. Everything is under the blanket of chemotherapy, but it used to be that they were cytotoxic, meaning they killed any cell that were trying to rapidly divide. And now we're trying to go to targeted therapies and immunotherapies that are hitting just the genes that are changed. And so patients say, well, why haven't we found a cure for cancer? We're going to go back to the fact that everyone's cancer is different. Because everyone's cancer is your specific cells that have changed the genes to then become cancer. So could we potentially find a cure for cancer? Yes, if we found a cure for every single person's cancer. And that's why I don't think it'll ever really happen. We'll find ones that are going to be great for a lot of people, but you're going to have some people where their gene change that caused their cancer, we don't have a target for. So we don't have a cure for their cancer because we don't have a drug that actually can hit their cancer genes that have changed. So that's the goal, is to find every single person who has cancer, a drug that can hit their genes that have changed to make their cancer. But will we be able to do that for everybody? I don't think so, unfortunately. Not in our lifetime. Maybe with AI in 50 years, but not right now. Resistance, we already kind of talked about that. So I put this slide in the middle because that's a lot of information. This is my favorite. Anyway, so because that's a lot of information. So does anybody have any questions at this point? Yeah.
What would your recommendations be for annual exams, like premenopause versus menopause, and also does insurance cover those kinds of things if they're saying you should only have it every 5 years?
So that's a great question. So as far as the pap smear screening, at this point, depending on your insurance, you're absolutely right. They're not going to cover except for 3 to 5 years for pap smears. But pap smears and pelvic exams are different. And so with an annual exam, I personally still at least discuss everything with providers. So at your annual, discuss how things have been down there. If you've had different changes in your symptoms, if you've noticed something different, then say, I'd like a pelvic exam. Because even if it's not a pap smear, which is technically different, you could still have a pelvic exam and that should be covered. But that should be something every annual exam, whether you're premenopausal or postmenopausal, you should at least have that discussion. Yeah.
If you've had a total hysterectomy, so you don't have cervix anymore, should you don't need a pap smear anymore?
So that's a great question too. So it depends on if you've ever had abnormal pap smears, which again is something that a lot of women don't remember because it's hard to remember if you've ever had an abnormal one. But if you've had abnormal pap smears where there have been a high grade change, meaning not a low grade, but actually one that is concerning for becoming cancer, after a hysterectomy, you're actually supposed to keep getting pap smears for 20 years after. But you have to know if you had a high grade change or not. And a lot of patients just know they had an abnormal pap, but they can't remember if it was a high grade or not. But the recommendation is after the cervix is gone, that you don't necessarily need to unless you had high grade pap smear changes in the past. But the problem with that is that HPV is still in the vagina and the vulva. So that's why I think those recommendations are going to change. because I don't think we're capturing a lot of patients who have HPV still that could potentially pop up as they get older because we're not papping them enough anymore.
Has there been any difference in thoughts about, doing a needle biopsy that actually spreads the cancer cells because of the needle?
So that's a great question. So the needles they use now are different. So they're trying not to use the kind that could potentially spread the cell. But the problem is it depends on what you're actually biopsying. So for us with ovarian cancer, we don't like needle biopsies because you could rupture the ovary, you could spread cells, you could biopsy the wrong part. So we hate that. Other areas, it's easier to do those needle biopsies, but it actually is less about the biopsy itself and the fact that those cells were already out there. It's kind of like the old adage that somebody went to surgery and then after surgery, their cancer went wildfire and they spread cancer everywhere because of the surgery. Those cells were actually already there. And after surgery, we can't do things like chemotherapy or treatment for those cells because of the fact that you're healing from the surgery. So it's less about the fact the surgery itself got those cells to spread. It's that they're there because we can't see cells. And then after surgery, because you're healing from the surgery, we can't do things like chemotherapy to get those cells to go away. And then they grow during that time.
I guess maybe I should have mentioned specifically a lump in the breast. That would be more not spread out,
Right. And
that lump when the needle biopsy then open.
well, and it's not necessarily that it broke open. It's more that those cells were already trying to get out, and it's just a bad timing of the two things. But I do know with specifically with breast surgery that they try and do more lumpectomies rather than do actual needle biopsies. If we can remove it, that's the best way to do it rather than do a needle. But sometimes there's no other way to do it. So that's a great question. So any cancer can, depending on the gene change. And part of the problem is we have patients who every single person in their family has a specific type of cancer, but they've been tested and it's negative. It's not necessarily that there's something that's not genetically in that family. It's that we don't know what it is yet. And so we can't find it. So the cervical cancer, for example, HPV is the driver for that. And so that's not technically hereditary, but if your immune system in your family is such that your family's immune system is not that great and you can't suppress the HPV, then potentially we do see that lots of people in that family have cervical cancer, not because of the driver of the cancer being HPV, being hereditary, their immune systems can't handle it. And so that's why it becomes a hereditary cancer. So you can kind of look at any cancer care as potentially being something in the family, either one, because of your immune system, or two, because we don't actually know what gene your family carries that could be causing the cancer. Yeah.
In the works for ovarian cancer screening.
So we used to do ultrasounds and CA-125. So CA-125 is a protein that your body makes and that a lot of ovarian cancers express. The problem is it's a non-specific inflammatory marker, and so a lot of other things can also have CA-125. So lung, heart, kidneys, liver, diverticular disease, a lot of different things can have CA-125, that protein. But we knew we couldn't use that as a screening tool because if we tested everyone's CA-125 in this room, including our gentlemen, they would all be on different variables in that range. And so we would not be able to actually say, okay, because yours was X, you have cancer. We can't do that. So we knew we couldn't use CA-125 by itself. So we tried to put it together with ultrasounds and do an algorithm to try and figure out if we could put those two things together to try and screen. That didn't do anything. It basically made everybody go out and get surgery for weird cysts on their ovaries, and we didn't pick up ovarian cancer any faster. So then they tried to use what's called an oval 1. So what that is a different algorithm of 5 proteins. So CA125, but 4 other ones, to try and see if that could screen for ovarian cancer. All that did was tell general GYNs, so GYN gynecologies, to then whether they could actually do the surgery or not. So basically, it's a tool for them to say, should I be doing the surgery, or is there an increased risk of cancer, and should I be sending them to GYN? So then they tried to use HE4, which is another marker out there, and that didn't do anything either. And the problem is because our ovaries have all of our genetic makeup and all of our cells to make babies, one screening tool for somebody is not going to be the same screening tool for somebody else. So they're trying still. The other ones that are kind of out there is trying to find proteins actually in a pap smear. So looking at the pap smear proteins and seeing if we can figure out if there's any proteins on a pap smear that's shed from the uterus onto the pap that could be. That didn't go anywhere either. Yeah, exactly. Exactly. Okay. So this is, we kind of touched a little bit about this, but this is one of those questions that every patient who has a cancer diagnosis is why. This kind of gets back to the genetic component of things, but also the fact that a majority of the time when we have a cancer diagnosis, we don't know this answer. And people can tell you what they think it is, and we as providers can guesstimate, but we are not there when that cell decides to become from a normal cell to a cancer cell. None of us are there at that time, and so we don't know why this is happening. We have guesstimations, but why it happened for you, we don't know. And so this is a quote that kind of talks a little bit about chemotherapy and the treatment of cancer, and the fact that when we treat cancer, a lot of the times we're so focused on treating the disease, we don't think about the patient. And so in our practice, we try very, very hard to remember that cancer is not about the cancer diagnosis. It's about you and what you are actually feeling, what you are going through, and what is happening with you. It's not about the cancer itself. And so how can we help with some of the different side effects of chemotherapy? Because there are quite a few. So there are side effects with everything that we do as providers. And so how do we help with those side effects? And how do we help with those things that are happening because you're getting the different treatments? And so depending on the chemotherapy, we have things like hair loss, which we already talked about. We have things like chemo brain. So it gives more of a brain fog after getting chemotherapy. We have problems with the heart. We have problems with the blood. We have problems with our nails. We have problems with our liver. We have problems with all this stuff from the cytotoxic chemotherapy, which we're now trying to hopefully get changed to be more targeted, so all of these side effects will be less. Body image, which we kind of talked a little bit about that too with the hair loss, but body image, especially after we do things with the lady parts, is very difficult for a lot of women after we have to do surgery, after we have things like hair loss. We don't feel like women anymore. And so how do we help support women to know that we're not just our lady parts? We are so much more than that. And how do we help overcome those self-image changes that are sometimes really jarring and very difficult? So it's a lot about trying to go from body positivity and body neutrality. So trying to describe the difference between these two is being positive about the faults that we have versus being positive about what our body can do for us. So accepting all of us, every single part of us, versus accepting just how our body can help us. And so how we kind of look at ourselves in the mirror is very much in tune with that. Are we liking what our body looks like and what our body can do? Or are we accepting everything that's kind of happened to us? And part of the side effect of chemotherapy and cancer care is a change in intimacy. We did a study during my fellowship talking about sexual function and sexual health in cancer patients. And we thought the reason why nobody talked about sexual function and sexual health is because we as providers were not asking those questions. Turns out on this survey, nobody wanted to talk about it. So the survey actually showed that the patients we asked, they're like, that is the farthest thing from my mind. I don't want to talk about sexual function. I don't want to talk about sexual health. I don't want to talk about any of that stuff. I don't want to talk about how I look. Nope, nothing, none of that. We would just kind of focus on the cancer care, but that is something that changes when we have different things that are happening to us, either surgery or chemo or radiation, is it changes our relationships with other people. And how do we help patients get through all of that and come to the other side for their new normal without asking those questions? But sometimes patients are like, and stop. Nope, we're not talking about that today. We will talk about that at some other point. But unless we ask those questions, sometimes we don't know if those are things that people do want to talk about. But intimacy, not only from a physical contact, but also intellectual intimacy, emotional intimacy. How do you ask for help when you're having problems in those areas, when you're also going through cancer care? And how can we as providers help with that? Pain is a big part of cancer care because we have pain. Fortunately, pain is something that, again, as we as the Western medicine have been trying to figure out how to quantify pain, we cannot. Your 10 is not my 10. Your pain is not my pain. And so how do we help patients express those pain and figure out how to help their pain in a way that's going to help them, as opposed to in a way that we think is going to work, because it's all individualized. That's the overarching theme of this whole thing, is everything is so individualized and so you, and so what is going to be best for you and how do we help you with your pain? Estrogen. We kind of talked a little bit about this, but this is one of those things that is out there as far as women's health and what estrogen does for us. So back in the day, in the 70s, there was a study called the Women's Health Study. Women's Health Study said that estrogen and HRT and hormone replacement is the worst thing on the face of the planet. Don't do it. Don't give it. Don't give any of your estrogen. You're done, period. The end. Now it turns out that that study was horribly flawed. And so we're actually looking at estrogen and the benefits for women and changing what we're thinking about estrogen. And so now we're actually going the opposite way, and everybody's getting estrogen or estrogen like compounds or what they can do to get their estrogen back or how they hold on to their estrogen over time. And so I think it's more of a middle. Is estrogen good for us? Yes, absolutely. Can everybody have estrogen replacement? No. Because depending on your risk factors, giving estrogen back to you after menopause is probably not a great idea because of the possible side effects of giving you estrogen back. So giving you estrogen by itself without giving you progesterone backing if you have your uterus still in place. Giving you estrogen if you have a history of blood clots, if you have a history of seizure disorder, if you have a history of, cardiovascular illnesses, things like that, if you have a history of breast cancer. So there are changes in what we can do as far as HRT with breast cancer patients as well. It used to be that if you had a breast cancer, you cannot have hormone replacement because of the risk of the breast cancer. Well, it actually turns out that estrogen alone is less risky for breast cancer survivors than estrogen and progesterone. So now a lot of patients are actually asking for estrogen. So it's more, again, talking about you, yourself, what your risks are, what you could potentially do to try and help with all of the lack of estrogen as we get. And so again, how do we make it better? How do we fix what's going on? How do we help patients who are going through their cancer care deal with some of the side effects of cancer care? And I love this quote because the single biggest problem in communication is the illusion that it's taken place. If I tell you something or we have a conversation and I think that I got some information across and you leave the office and you're like, I have no idea what the heck just happened, then that communication did not work. Or if you are telling me something and I'm not hearing what you're saying and you think, well, I told my provider X, Y, and Z, and I'm like, I didn't get that at all. So that's the biggest problem, is that making sure that when we talk to our providers and talk to our patients, that we actually are on the same page, because a lot of the times we think things as providers and we say these words and we're talking, like I said, talks like a mile a minute. And then at the end of the day, you actually have no idea what I just said. Yes.
Dr. Dixon, we got a question on tips for you.
Oh,
The question is about preventative options. So this person writes in that they had endometrial and vaginal cancers 34 years apart. Then they had ostomy and had 56 hyperbaric treatments, 2 hours each. She's wondering if there are doctors out there that are providing more preventative options.
the preventative, I guess I don't understand the question. So preventative, like to not have that happen?
Let me ask if she can explain.
Okay. Because I don't know prevent what.
I think she can hear.
Okay, great, fantastic. I would love to answer the question, but I don't know how. Okay, so do we want to keep?
She's still typing.
Okay.
We'll circle back.
Okay, let's circle back. Okay. Okay, so cancer and stress. We kind of talked about this a little bit, but really, how do we help everyone with their stress levels all over the place, everywhere? Because every single person in this room is stressed about something at some point. And every single person out there who is being treated for cancer, as soon as you hear the word cancer, you are stressed out. Like you can't hear the word cancer and not be stressed. Like it is impossible. So how do we help decrease these stressors to try and help get that cortisol level, which we know is so much of a function of cancer care? How do we get that to get better? And really it's looking outside the box. And so take that back. All of the things we do to treat cancer are stressful. Surgery is stressful. Chemo is stressful. Targeted therapy is stressful. Wondering about whether there's going to be a recurrence is stressful. Radiation is stressful. Everything is stressful. And so how do we help decrease that stress? We have to really think outside the box of what's going to be best for you. Some patients love exercise and love doing exercise and working out and working physical therapy and being active. Some patients don't. Some patients love cooking and going out with friends and having an occasional glass of wine, which is fine to have an occasional glass of wine. Are you having a bottle of wine every night? No, that's not a good idea. But having an occasional glass of wine is fine. Having a cookie is also okay. Everything in moderation, but what's going to help decrease your stress level. And we have to find out what's best for you, not what's best for anybody else, and making it individual. So how do we help get the mind, the body, the behavior, everything to kind of help with that stress? And so there's different ways to do that. And so a lot of the things that are not unfortunately covered by insurance or have a lot of studies to help us know that they actually work on patients is kind of the different alternative medicines. So chiropractic, acupuncture, aromatherapy, Reiki therapy, massage therapy, all of this stuff is out there and it works really well for people, but unfortunately it's expensive. Insurance doesn't cover it and there's no studies to say it really works. But if it works for you, it really works. So what can we do to try and help patients have more exposure to these to try and help them decrease that stress level? So if you are a patient who doing physical activity or working out stresses you out, then maybe that's not what we should be doing. Instead, let's find something that actually helps with your stress level and not somebody else's stress level. So what can we do? And then different ways to kind of help with intimacy. Again, it's about what works best for you and communication. You can kind of see in every one of these different parts of the slide, it talks about communication. And again, unless we know that communication actually has worked and we do a back and forth to make sure that we've actually gotten our point across, we don't know if communication actually happened. Acupuncture, again, there have been studies that have looked at acupuncture for things like nausea, for things like neuropathy, for other things like hot flashes, vaginal dryness, things like that. But again, it's not covered by insurance. And so a lot of this is prohibitive to some patients because it's of the cost. But what can we do to try and help with all of these different side effects of the things that we did from our treatments? Has anybody ever done Reiki therapy? It's weird, but it works. So Reiki therapy is basically an energy. And so the Reiki therapist actually doesn't touch you at all, but it helps kind of direct your energy. And it's something that's out there that a lot of people don't know about. And some patients, like, for example, going back to acupuncture, they say, well, I'm not doing that because I don't like needles. Well, you can do needleless acupuncture. And some people are like, well, I would love a massage, but I don't want anybody to touch me. So Reiki therapy actually works really well for that because they don't. But it's a very similar process of trying to help with your energy and trying to help with your stress level with Reiki therapy. Yeah. Yes. Yeah.
So it's similar.
Exactly. And that's the thing, because a lot of people don't even go down that road because they don't want to be touched. So what are the different options that are out there that can help with patients who want the same benefits, but they don't want that physical touch? So voice. The big thing about making sure that communication happens is to actually speaking. And so, unfortunately, this is something that a lot of patients say when they come to our office is that I've been telling X this for how many months and no one's been listening to me. If you feel like you have something that's going on with you and that you don't feel like your providers are listening, find another provider. If you don't feel like you're being heard, find somebody else to hear you. There are a multitude of different providers, even with insurance difficulties, that you can go and find somebody that actually gels with you and you feel like you're being heard. Because it's not just one person. Everybody in this room is not somebody else's cup of tea all the time. And so finding somebody who actually will listen to you, that's the number one step to cancer care, is making sure that you're being heard. And so to be heard, this is actual quotes from people who have had cancer and who have done therapies for cancer and what they recommend and what their thoughts are. And so some of the ones that we kind of focused on are, which I talked about as well, don't dwell on statistics. So when patients come in and ask me, well, what's my prognosis? How many more months do I have? I say, nobody knows. You don't know, I don't know, the man upstairs may know, but nobody knows. So that's the problem with stats, is that they are all of the people who have been diagnosed with X. So not only are they the really good outcomes, but they're also the really bad outcomes. And everybody's averaged together. So those stats mean absolutely nothing, because it's about you and what your genes have done to change your cells and how you are going to be moving forward. So this is your experience. And knowledge is power. If I'm not telling you answers or giving you information, then find somebody else who will. There are good, reputable places to get information from that aren't necessarily just ChatGPT, which I still think is evil. But there's other places like the American Cancer Society, the Wisconsin Ovarian Cancer Alliance in Wisconsin is a great place. The NCCN, which is the National Cancer Network, they have great resources. It's very scientific, so sometimes it's over people's heads, but it's great information. So there's places to get the information, and if you don't know where to ask your provider. Say, I'm looking for information about X, where can I go? But getting that knowledge is really helpful, especially with a cancer diagnosis. And we are a team. So it's not just one person. You are not alone. Every single person in our clinic helps patients. And so we are a team, and it's not going to be you by yourself. We are going to help get you through that cancer care and help to get to the other side and help to be a different person at the end that you are going to be okay with. And how do we help you be okay moving forward? So what questions? Yes.
Okay, so question from online.
Yes.
So she states that once she had her ostomy surgery, there were a few options to make sure that her colon doesn't have an issue. And there are so few doctors who want to get involved with something. She's speaking from the point of view of living in a smaller town that you have to travel 200 miles or so to get to a bigger hospital. So are there better preventative treatments available for this scenario?
So What I think that she's asking, that sounds like she had endometrial cancer and then she had a vaginal recurrence of her endometrial cancer, which typically we treat with radiation. The problem with radiation, it can cause a lot of bad side effects. Oh, computer. Sorry. So then the radiation itself, the treatment for the cancer actually can cause problems down the road in the vagina. And because, as we talked about, the bladder, the vagina, and the rectum are all right on top of each other. And so then we can have problems with the colon. And so trying to help decrease those problems afterwards, she said that she had had hyperbaric oxygen therapy, which is one of the different therapies that we can try and do to help with radiation changes. But the problem is we don't know who's going to have those radiation changes when we're doing the radiation, because we don't know whose tissue is going to have the bad problems down the road of necrosis and tissue death and things like that. So the problem, which I'm 100% hearing, is there are not enough providers for the number of people who have a cancer diagnosis in rural areas. And so the big thing with that is going to be trying to help get the primary doctors who these patients are going to be seeing to understand what is a potential side effect of these treatments moving forward. So as far as preventative, the only real preventative for radiation long-term changes in the vagina and the colon and the bladder is to keep doing exams and to potentially do that hyperbaric oxygen therapy sooner, because it's picked up that there's a problem with that radiation change sooner rather than later. But hyperbaric oxygen is another thing that's not necessarily everywhere. So to answer her question, there isn't very much, unfortunately. And it's more about annual exams and going in to seeing your primary doctor and talking about symptoms and things like that. But there are also not enough of us, and there's not enough of colorectal, who probably did her surgery. Unfortunately, there's only 1,500 of GYN oncologists in the country. So there's only 1,500 of us, and colorectal is about the same. So there's just not enough people going into this field. So it's a depressing answer. Questions? Thank you all.
Thank you for sharing your time. Yes.
And if you do have any other questions, I think you can get a hold of us. As people who know me know, I'm kind of anal for answering questions.
Thank you guys, everybody. Thank you for joining us. We'll have another one soon that'll come out with the BayCare newsletter and on our Facebook page. And there's plenty of resources over there as well. And to Dr. Dixon's point, we're very lucky that we live in a community that has her expertise and services, because there are so few gynecological oncologists throughout the US. Women have to travel to get care in a lot of places. And same with colorectal. So we're very thankful to have her, and we're very thankful to have all of you guys learning about all this. Have a great day. I was your second one was mine. So I know what's the other piece. The ones. Yeah. So. I would put it up. Ready with control of the second.